Joining us now to talk about your health is Dr. Khalid Kurtom, a neurosurgeon at University of Maryland Shore Regional Health. Doctor, thank you for joining us.
Thank you for having me. I appreciate being here.
Tell us about your practice. What do you spend most of your time on?
So I'm a general neurosurgeon with a focus of minimally invasive surgery. I'm on the Eastern Shore. I take care of 5 counties here. Majority of my patients come from, anywhere from Maryland, Northern Virginia, and DC. And like I said, I focus mostly on minimally invasive surgeries, different ways of doing operations in a small fashion to get the maximum outcome and get people to recovery in the fastest way possible. So that's what I do. I do brain tumors, spinal tumors. I do spine surgery, peripheral nerve, vascular disease. So I do quite a bit of different variety of neurosurgery cases.
Well, let's start with the spine, because so many of our viewers, I'm sure, have back pain issues from time to time. When does that become an issue that you go to an orthopedist for versus a neurosurgeon?
It's a great question. So first off, the hope is that you don't end up with a surgeon, period. So, for me, I pride myself on being a very, very conservative surgeon. So I advocate for people to have healthier lifestyles, watch their diet, and make sure they watch their weight, exercise routinely. And then when they do develop pain, I encourage people to maximize conservative management prior to doing anything surgical or anything invasive. What I mean by that is over-the-counter medications, anti-inflammatories, muscle relaxants, sometimes pain medications, but mostly exercising, therapy, and in advanced cases, injections and kind of pain management procedures prior to even thinking about seeing a surgeon. And if you get to a point where you do all those things and you fail, then the next step is a surgeon. And for the spine, orthopedic surgeons and neurosurgeons both do spine surgeries. So and they're both equally very well trained to do it. So, based on availability and who you can get in to see, the next step will be to see one of us.
Is the typical issue there disc related with, some degree of compression, and that's a problem that would go to either specialist?
Yeah, so majority of people have herniated discs or degenerative disc disease or slippage of their vertebra. And sometimes, some people have advanced spine disease where they have deformity, where their spine alignment is off. So that can cause a lot of pain. And depending on what they present with, usually, some surgeons are okay doing massive, big, corrective spine surgeries, and some are trained in minimally invasive surgeries. And I would say there's a lot in between those two categories. So these are the two ends of the spectrum. For me, I am more specialized in doing minimally invasive surgeries, the surgeries that are mostly outpatient. So an example is like a neck operation or a low back surgery. Most of my patients go home the same day after surgery. Versus if you've had a big open procedure, you're usually in the hospital overnight and usually a few days in the hospital with extensive recovery and rehab.
Talk about, you mentioned minimally invasive procedures a couple of times. What are the big advances there? Is it a matter of new technology? Is it a matter of new techniques?
You got it. Yes to both. Yes. So the point of minimally invasive surgery is you have to get the work that needs to be done deep into the spine through minimal openings. So let's say you have to remove a disc or fuse a spine. You want to do that through a very small opening without cutting the muscle, without destroying the tissue to get there. Which, if you intuitively, if you think of it, you're limited in the way that you move your hands and the space that you have to work. So to do that operation, you have to kind of relearn anatomy and be proficient in doing microsurgery. And then you got to be able to use all technology that's available to you to do that safely. So if you look at like open surgeries versus minimally invasive surgeries, the technology that's employed is significantly more involved.
How about the advances in imaging that make your work possible? When you're talking about brain surgery, the ability to know exactly what you're getting into, where you're going, how much has that improved over time?
Yeah, so now we're able to actually put a probe on someone's brain and know exactly where they are, where we are. We also have the ability to, in the operating room, know how much tumor we resected and how much more we have to take out, and know where we are in the spine, and safely put in hardware that and avoid the nerves and the spinal cord. So yeah, imaging has advanced our field significantly. Navigation in the OR, robotics are all things that I think we're at the tip of the spear when it comes to the technology in medicine, because obviously we rely on it significantly for safety.
How much of your practice, especially the surgical interventions that you need to do, would be a result of injuries, either accidental injuries or sports injuries?
Yeah, so yeah, it depends on the age group, right? So the teens and the 20s and early 30s, typically those are accidents. You know, the majority of those patients are usually injured, whether they're playing sports or driving cars or doing, motorcycles, et cetera. As you see the older population, that's mostly degenerative spine disease. That's just aging of the spine, wear and tear, people that have had hard jobs for a long time, people that have been overweight or not exercising for a long time. These are the people that end up showing up with issues as they get older. And then in the most in the elderly population, people above 70, 80, usually has to do with bone quality, and how much bone density they have. So that plays a big factor as you get older.
Do concussions figure into your work?
Yeah, so I see a lot of athletes. I have a general neurosurgery practice, so anytime that someone has a concussion, they usually, and mostly for the younger patients, it's usually for the parents, because most of those patients don't have any bleeding in their brain or anything like that really needs my help. But the majority of those patients end up coming in just to get evaluated and to get resources as far as what to expect and what the recovery is like. So I see a lot of that, but thankfully less and less, because our sports now are becoming safer and safer. We're putting a lot more rules in, and kids are educated significantly on what's appropriate as far as impact versus not.
It's often difficult for patients, parents of younger patients, as you mentioned, to figure out how severe a concussion might be. What would your advice be in deciding when you should give it a little bit of rest, when it's primary care, when it's an emergency room? So
every concussion needs to be evaluated by a medical professional. So I would not take concussions lightly at all. No matter how minor it looks in the field, obviously remove the player off the field and completely off the bench. They need to be evaluated by a medical professional, and medical professionals know what to look for as far as symptoms that need imaging, need scans of the brain versus just observation. But long term, let's say somebody comes in and they've gone through the initial process, but they're still having headaches, having trouble sleeping, issues with appetite. Those patients, I advocate that, my strategy is limit activity and excitement to your brain until you see signs that the brain is recovering. So, and as you start to see those signs, you can increase your activity appropriately. And if those signs come back, then you come back on your activity level. So it all depends on how the kid is feeling and or the patient is feeling, and how much more advancement of their activity they can do.
Always intrigued in reading about your work that was particularly a case of a patient whose brain operation was a big success, needed to be awake during the operation. Why is that necessary sometimes, and how do you deal with pain while the person is able to communicate?
That's a great question, and that's what a lot of people want to. Those cases are far and few in between. Unfortunately, I've done a large number of those cases just because I've been in practice for a long time and I have a high volume. But basically, in a nutshell, those patients end up having a brain tumor that's very, very close to areas in the brain that are highly functional. And to do the operation safely, you have to be very sure about the area that you're cutting versus the area that you have to leave behind. And the only way to do that with 100% safety is by keeping them awake. And while they're awake, you test these areas, and you can recognize which area is responsible for function and which is not. And then the areas that have a tumor in it that is not functional, you can cut out. That's in a nutshell. As far as pain, what's interesting is that all pain in your body is received by your brain, but the brain itself has no pain sensors. So once you cut this, once you numb this, the scalp and the skull, and you do that part of the operation, the rest of it is painless. That you can cut as much of the brain as necessary without the patient feeling anything. So it's really odd. Those cases are, like I said, they attract a lot of attention because you're literally talking to the patient the entire time in the operating room and asking them to do things, and their brain is exposed in front of you.
Doctor, I have time for a one-sentence answer on this. What's the most exciting thing happening in your field, the hottest research right now?
Well, I think right now it's mostly what we talked about earlier, robotics and AI technology, and how we're going to incorporate that into my world. That is the most exciting thing that's coming up in the near future.
We'll look forward to talking that in the future. Dr. Khalid Kurtom at the University of Maryland Shore Regional Health.